So, hello everybody. My name is Dr. Saif, and I'm a critical care consultant at Bahrain. And just to introduce myself, I have completed MD and DNB in anesthesiology, and after that, I have completed postdoctoral fellowship in critical care anesthesiology from JIPMER, and then I had some experience. Thereafter, I completed DM also in the critical care medicine from Tata Memorial Hospital, Mumbai. Following that, I have been in academics. I was professor, associate professor in the Department of Critical Care at RIMS, Ranchi. And then I moved to Bahrain. And since last 1.5 years, I am a consultant and program director of critical care program for the Saudi board. So this is my small introduction. And this presentation, this teaching session is for all those students who are preparing for anesthesiology final exam, or the students who are going to present for critical care entry level exams for various courses in critical care medicine, and even for the super specialty anesthesiology courses. Okay, so the topic is interpretation of low volume loops. Okay, so we know this is important topic because it has significance in detecting various issues in patients who have developed various pulmonary diseases, especially the obstructive pulmonary diseases and the restrictive patterns, and also various airway obstructions. So basically, this is important kind of investigation which can assist you to diagnose various obstructive abnormalities as well as restrictive and neuromuscular weaknesses. So this is going to be very interesting. It may be the part of your viva or your practical examination in anesthesiology, and it can also be asked as an MCQ. So the content of this session will be as follows. So we will learn what is the loop. Then we will know what is a normal flow volume loop, how to draw it in exam for patient who is spontaneously breathing, especially, yeah, so this is more important in patients who are cooperative, who can perform spirometry. As you know, the flow volume loop can be only obtained in patients who are cooperative and who can forcefully exhale. So this is how we draw, how we obtain the flow volume loop in a spontaneously breathing patient. And also we can we know that this is the part of ventilator graphics in patients who are on mechanical ventilator, the patients who are even uncooperative for various things. Obviously, in such patients, we can obtain F.V loops on ventilator screen as a part of our ventilator management and the volume scalars and loop analysis. So let's understand what a loop is. A ventilator, the flow volume loop is basically a type of loop. So the loop is a real-time graphical representation of two variables plotted against one another. Okay, so two variables which are plotted against one another over the graph, that is your loop. Okay, so what are the variables which are important in the respiratory physiology? So it could be pressure, it could be volume, and it could be flow. So flow, pressure, and volume. There are three important variables. Could be independent variable, dependent variable. We are not going into this discussion of which one is which, but we should know that there are three variables, and the relationship between any two of variables can be graphically represented on a paper or on the screen, and which is called loop. Okay, so this is the basic definition of loop. Whereas scalar or curve is basically only one variable which is represented over the graph in relation to the time, like volume, time, pressure, time, and flow time. So there are three scalars, and we have most commonly two types of loop: the flow volume loop, as you know, and as we are going to discuss today. And then we have the PV loop, that is pressure volume loop. That is also very, very important type of loop which we usually look at the screen of mechanical ventilator and can draw important conclusions about the patient's condition, patient's lung condition and respiratory system condition. So let's start with the case. A 48-year-old female patient presents to the pre-anesthesia clinic to prepare for a knee arthroscopy procedure. The patient has a history of chronic cough for past 1 year. Vitals are heart rate 72 per minute, blood pressure 140 over 74, SpO2 93% on room air, and temperature 36.6 degrees Celsius with height of 64 inches and weight of 88 kilograms. Pulmonary function tests including a flow volume loop were present in the patient's medical records from an outside hospital. So this is the usual scenario. You look at the pulmonary function test obtained from the patient's record. They will present to you for a pre-anesthesia checkup, and you have to look at the graph, you have to look at the reports, and then you need to find out what kind of abnormality patient has. So this is the basic minimum information which you have to look at, and then you need to understand what has happened to the patient, what is the diagnosis over there, and how fit they will be for the surgery. Okay, so how you are going to give them fitness. So this is an important job for anesthetist. So now look at this graph. Okay, this is a graph here which I'm showing over here, and with this graph, can you just guess what the problem is? What the problem is with the patient's respiratory system? So as you know, this is a flow volume loop. So y-axis there is the flow, and x-axis there is the volume, and this is the graph, and there are multiple graphs, kind of multiple curves and graphs, I mean the loops, and there is a smaller loop inside also. So this is quite looking complex for you, right? But if you look at the key over here, which type of loop, what I mean, this is a colored there are various colored loops, right? So you can just see the which is the best one, and then there is 1, 2, 3, 4 various settings in which the loops were obtained, and this is your pre-bronchodilator loop, and then there are post-bronchodilator loops. So all are available here, right? And so we are going to discuss it later. Just keep in your mind that this kind of question may be asked in your exam, right? So this is just a kind of example that this may be a question for your practical exam. Now let's start with the basics. Okay, so what a normal F.V loop in a spontaneously breathing patients look like? So how will you draw? How will you draw a flow volume loop? This is more important. In exam, they might ask you, I mean, the examiners may ask you to draw an F.V loop. Okay, so this is your loop. So first you have to draw the y-axis, then x-axis. And in x-axis, you need to, this will represent the volume. The volume will be plotted on x, and flow will be plotted over the y. The flow will be, the unit of flow will be liter per second. Okay, the flow will be liter per second, and the volume will be in the liters. And then you start from here. So basically, there are two parts, so upper and lower part, above x-axis and below the y-axis. Okay, so this loop has two parts, upper part and lower part. The upper part is basically expiration. All right, so you have to inhale to the maximal total lung capacity. So this volume here represents the total lung capacity. So you have to maximally inspire like this, and then forcefully and maximally, as much as you can, you have to expire like this. Okay, so this graph will be obtained. So you need to expire forcefully. So rapidly, as you leave the air out of your lung, what will happen? There will be a flow, right? So there will be expiratory flow. This flow represents the expiratory flow, and it will be very rapid. As you can see, this graph, or you can say this line, this curve is very fast approaching to the maximum, right? So this part is very fast and this part is little slow. So this is basically increasing the flow, and then it goes to maximum and then it starts decreasing later. In the later 2/3, or you can say 75% of the time of expiration. So initially it goes very fast to the maximum flow. So that is your peak expiratory flow, and then it starts descending down and descending down till you go to the maximal time, maximal point of expiration. Okay, after this you cannot expire more at all, and this is the point where you will stop the expiration, and this point represents the residual volume. So still you will have some air, some volume of air left in your lung, and that is your residual volume. Okay, so you start from total lung capacity after maximal inspiration, and you just expire completely, and at the end of expiration, whatever is left in your lung, as you know, is residual volume. So this is on x-axis, the minimum point. You can say it is basically the volume is represented negatively. So you start from maximum inspiration and then you take out all the volume and you reach this point. So between this point and this point, what is the difference? So the difference between the total lung capacity and residual volume is known as, so what is that? What do you mean by TLC minus RV is equal to forced vital capacity. So this is your vital capacity. Okay, from this point to this point is actually a vital capacity, right? Just remember this. Now, from this point onwards, what you will do is you inspire. Okay, so this is the point where you will start the inspiration without wasting any time, and it will be like slow, and then it will reach to the maximum, and then there will be a kind of plateau. Okay, I mean, you can say here it will reach the maximum inspiratory flow. Okay, from here to here at this point, this is your maximum point, maximum flow rate in the negative side. That is your inspiration, and then you slowly come. The flow comes down and then reaches to the total lung capacity. So you inhale. So initially you inhale faster a little bit, okay, and then your inspiratory flow becomes kind of static, plateau, and then suddenly it will reach to this point and inspiration will stop. So this is whole kind of interpretation of flow volume loop, how it is, okay, physiologically. So this part, the air is leaving out of your lung, and what is happening inside you are expiring. So basically inside there is a positive pressure, right, until the pressure becomes completely equivalent to the atmospheric pressure. Then you're from here onwards, your diaphragm descends and you create negative pressure in the pleural cavity, and expiration starts until it becomes complete total lung capacity here. Okay, and that is again one point. This is the point where the pressure inside will be equivalent to atmospheric pressure. Okay, so I'm not going to talk about pressure here. It will become too confusing. Just remember the flow and volume. I already explained to you that this is your total lung capacity and this is your residual volume. And the difference between the total lung capacity and residual volume is the forced vital capacity. This part is expiration. It has typical graph or a typical pattern, and then this is your inspiration. And look at peak expiratory flow rate. So we'll talk about this more. So what is this? So this is peak expiratory flow rate, and it is higher than peak inspiratory flow rate. If you compare, obviously this is a little bit like 3 or 4 times higher. So normal peak expiratory flow rate, that can be asked in your exam, so you need to remember it. So just memorize it. The peak expiratory flow rate is usually 5 to 6 liter per second. Okay, the normal peak expiratory flow rate 5 to 6 liter per second. In liter per minute, it will be 300 to 500 liter per minute. Okay, just for your reference. So you can also refer to various textbooks and internet, so various review articles. So it is given in a range So 300 to 350 liter per minute or 5 to 6 liter per second is the normal peak expiratory flow rate at this point, where the flow will be the maximum in expiration. And normal peak inspiratory during expiration, normal peak inspiratory flow rate will be obviously less, and that is about 40 to 100 liter per minute. Okay, so about, you can say, 1.5 to 2 liter per second. So it is just exactly 1/3 of the peak expiratory flow normally in a spontaneously breathing patient. All right. So I hope that you have understood the graph very well. And I will discuss this graph again when I will go to the mechanically ventilated patients. What happens to FV loop in the mechanically ventilated patient, that will become very interesting. So just I'm going to discuss now other points. So what are the patients in which it is difficult to obtain? So first question is how to obtain the FV loop. So this is a picture which depicts it all. So you have a man who has this mouthpiece of this machine, which has a lot of sensors, basically the flow sensors. Okay, so this machine has flow sensor which is connected to this monitor, and this monitor will draw this graph of flow volume loop. So basically, there is a nose clip, so you have to close the knob with the nose clip, so there won't be any nasal breathing at all, and the volumes and flow will be accurately measured. So there shouldn't be any leak as well. So this has to be kept in mind by the technician who is performing the procedure on this patient, okay, and measuring the flow and volume and pressures, etc. So the patient will be asked to inhale maximally to the total lung capacity and then start exhaling as fast and as forcefully and to the maximum as he can. Okay, so this is the instruction, and it will be done at least 5 to 6 times, and most appropriate graph will be selected. Okay, so the way, and then patient will be asked to inspire also. So inspiration will be quiet and in a normal way, but expiration will be forcefully. So this expiratory part is more important for the flow volume loop. But for that, patient has to be cooperative. So this loop is difficult to obtain in patients who are uncooperative, who are demented, who are elderly, delirious, and psychotic patients, the patients who have some mental issues. The children we cannot obtain, and in patients who have respiratory distress or patients who are critically ill, obviously in such patients we cannot perform this kind of test. So now, or can you tell me this? What is this? So this is also a spirometry, but this spirometry, different kind of spirometry, and that is your incentive spirometry. So incentive means that positive feedback. So this spirometry is used by the physiotherapist, especially respiratory physiotherapist, and this is a handheld medical device, and this is basically, this device is to encourage the patient's lung capacity, especially after extubation in the mechanical from the mechanical ventilation, liberation from the mechanical ventilation after extubation of trachea in critically ill patients or patients who have just finished the major surgery. In such patients, is very vital, and as you know, as part of your anesthesia practice also, you should know this device very well. But this is different from the usual spirometry. This is a kind of physiotherapy device. Okay. Now we will discuss about shapes of FV loops. This is more important for today's class. So interpretations of various types of loops, FV loops in different conditions. So we will draw first normal. Now here we have drawn the loop from this point. This is your expiration, and that is your inspiration. This is your TLC, and that is your residual volume. And then there is a smaller loop also here, which is called tidal volume loop. Okay, this is a small loop. This represents the quiet tidal ventilation only. Okay, so this loop will be obtained in a usual spirometric FV loop, which may be kept in your exam. So this kind of small loop inside the standard loop is called TV loop, okay, tidal volume loop. So this you remember, all right? And you should also remember the FEF 50%. What is FEF 50%? This is basically force FIF 50%. So forced inspiratory maximal flow. So basically, this is other name for the maximum inspiratory flow, or you can say the peak inspiratory flow, other name for peak inspiratory flow. So at the 50% of vital capacity, the peak inspiratory flow is usually maximum. So this is why it is called as forced inspiratory maximal flow, or FEF 50%. Okay, and this is your PEFR on the other side at the expiratory limb. So this is your maximum, and from here, this is forced expiratory maximal flow at 25% and then 50% and 75% at the vital capacity. So this is in relation to the vital capacity. Okay. So at 25% of vital capacity, 50% and 75% of vital capacity. All right. And vital capacity is between the TLC and flow and residual volume. Okay. So now we will discuss various types of variation. So draw, this is the question. Draw an FVL, the flow volume loop, for a patient with vocal cord paralysis. This is common question. Maybe asked in your exam for even FRCA and for Australian anesthesia exams. This could be asked. Okay. So draw an FVL for a patient with vocal cord paralysis. So vocal cord paralysis is a condition where you develop kind of obstruction. So the patient will develop inspiratory upper airway obstruction, inspiratory stridor. Okay, so it will produce a stridor. As you know, stridor is a noisy respiration. So patient will start inhalation like this, and then there will be a noise. So like this. So patient will be appear to be in respiratory stress as well. So like this. Okay, so it means that there is some obstruction inside the upper airway, outside the thoracic cavity. So this is basically an example for a variable extrathoracic obstruction. Variable extrathoracic obstruction, most commonly caused by vocal cord paralysis, and in which what will happen to the FV loop. So there won't be any change in the expiration. Remember this, okay? Expiration will be okay, but inspiration will be obstructed. Inspiration will be obstructed in the vocal cord paralysis, and that means that your peak inspiratory flow will be less. Okay, so you can draw like this. So there will be a kind of this type of curve in the inspiration side. So truncated or flattened inspiratory limb of this FV loop. Okay. So this will be like this. So it will not be smooth like this. It will be like this, in which you can say that peak inspiratory flow, or FIF 50% will be less than normal. Okay. So this is a very typical FV loop in all extrathoracic obstruction. So what are the various causes of extrathoracic obstruction? So what are the causes? So vocal cord paralysis is one of the causes. There can be thyromegaly, trichomalacia. Trichomalacia is obviously a cause of variable obstruction. Sometimes there will be obstruction, sometimes there may not be obstruction. And neoplasm. Okay, so anything can cause variable extrathoracic obstruction. But the vocal cord paralysis is the most common cause. Okay. Vocal cord tumor can also lead to, but that will cause fixed type of extrathoracic obstruction, not a variable one. So remember all these causes. Remember that there will be a blunted inspiratory flow, okay, or truncated or flattened inspiratory flow. But there could be various names for the same condition. All right, so I think you can remember this variable extrathoracic obstruction flow volume loop. Now we'll move on. Okay, one more thing. So this is interesting. So what happens during aspiration? So when you inspire against an obstruction inside or outside obstruction, whatever, extrinsic or intrinsic obstruction. So when you inspire, so there will be a Bernoulli's theorem and there will be drop in the pressure post obstruction. Okay, so the flow will be fast because there is a narrowed orifice. Okay, so there is a narrowed opening. So opening is narrowed due to obstruction. So the flow when you are inspiring will be little initially faster, and post flow there will be a drop in the pressure, and that pressure drop will cause the collapse of the airway. Okay, so this collapse of the airway will be variable collapse of the airway. So this is how it is. So if you read the physiology, you will be more clear. But this is like this. So post obstruction, there will be drop in the pressure and there will be collapse of airway. So that is your variable extrathoracic obstruction. Now look at this. So this is a CT scan of a patient in which there is a retrosternal goiter in the mediastinum. So this is your sternum. This black thing is lung. There are ribs. All right. And this is your trachea, which is deviated by the retrosternal goiter. So what happens in retrosternal goiter? So there will be intrathoracic obstruction of airway. So what does an FVL, that is FV loop, typically look in case of enlarged lymph nodes or retrosternal goiter in the chest cavity around the airway? Okay. So what happens in intrathoracic obstruction, variable intrathoracic obstruction? So let's examine the loop in this case. So the loop will be like this. So this inspiration, just look at the inspiration. Inspiration will be normal completely and expiration will be blunted. Okay. So there will be truncation or blunting of expiratory flow. All right. So very severely diminished. It depends on how much obstruction, how much compression is there at the inside the thorax of the airway. So it could be at carina, it could be at tracheal level. Okay. So there will be obstruction and the flow will be diminished. The expiratory flow will be diminished more than 20 to 50%, as you can see here. But the inspiration will be completely normal. All right. Now we will move on to the next part. Explain what an FVL for a patient with a fixed obstruction such as goiter looks like. So this patient has goiter, and suppose this goiter is a long-standing goiter. There could be obstruction. There could be no obstruction, which is fixed obstruction. Or other causes, the fixed for the fixed obstruction or fixed airway obstruction is the stenosis. So airway stenosis or tracheal stenosis can also cause the similar picture. Okay, so what will happen? What will happen to FV loop? What is the variation now? So in this case, in the case of fixed obstruction, fixed airway obstruction, both inspiratory flow and expiratory flow will be blunted. The truncation will happen in both flows, expiratory flow and inspiratory flow, as you can see over here. Okay. So both flows will be diminished and there will be flattening of flows over here, right? The plateau phase. So this is very typical for the fixed obstruction. What are the causes of fixed airway obstruction? There could be a tracheal stenosis. Okay. There could be foreign body inside the airway, which is fixed, which is not like acting as a ball valve or mobile foreign body. It is a fixed foreign body at some place in upper airway. And another causes the mass. Either it could be a neoplasm or just simply a thyroid gland enlargement. All right. So remember these three very well. I think you are very clear. So in extrathoracic variable obstruction, there will be no issue with the peak expiratory flow, but there will be truncated inspiratory flow. In case of intrathoracic obstruction, there will be problem with the expiration, but the inspiration will be normal. And in case of fixed obstruction, both inspiratory flow and expiratory flow will be blunted. Okay, I think you are now very clear about these three varieties of obstruction. And I'm sure you will never get confused, because here you can compare all these causes of obstruction, all these types of obstruction very well on FV loop. All right, I will move on. All right, so what happens in COPD? So draw an FVL for a patient with mild COPD, describe some key characteristics, explain what happens to the low volume loop whenever there is a severe COPD. So this in this case, the question is asking both mild and severe COPD, what happens to the FV loop. So in the mild COPD, peak expiratory flow rate, remember that peak expiratory flow rate is usually decreased slightly, okay? It usually decreases slightly so that the initial expiratory flow is not affected significantly. And there will be a pattern, which I'm going to show you in FV loop, which is very typical of the COPD. Okay, so I'm going to show you now. So this is your pattern. So what happens initially in early airway obstruction, there may not be significant drop in the peak expiratory flow rate. So what is normal peak expiratory flow rate? The normal peak expiratory flow rate is about 300 to 500 liter per minute, okay, or 5 to 6 liter per second. So maybe there will be 1.5 liter per second of drop in the peak expiratory flow rate, but not much in the early stage. Okay, but if you look at the pattern of the drop in the expiratory flow, it will be like this concavity. There is a concavity here, and this is known as scalloping or scooping, scoop out appearance. Okay, scoop out means, as you know, in ice cream, so you have to just scoop out. You scoop out ice cream and put on your cone, right? Or whenever you go to ice cream parlor. So what you do, you just scoop out. So here also you have scooped out this curve, and that is your scoop out appearance or scalloped appearance of expiratory limb of this FV loop. Okay, but there is no diminution or decrease in the peak expiratory flow rate. Inspiration is completely normal in the COPD. Usually in early stage. In later stage, it could also decrease. The inspiratory flow also can decrease. So that we are not going to discuss much. Just remember simply that in early stage, peak expiratory flow rate will be diminished just 10 to 20%, not much. But the appearance will be scooped out, appearance in the expiratory flow, the descending limb of the expiratory flow. Now, here, airflow obstruction, in case of severe COPD, what will happen? There will be drastic drop, significant drop in the peak expiratory flow rate. Okay, more than, you can see, 25 to 50%, even more, 75% in the peak expiratory flow rate. So the expiratory limb of the FV loop will appear as a blunted, but the appearance, the typical appearance will still be present, that is scooped out appearance. So scooped out appearance is a kind of a signature of COPD on FV loop. So that is what you can see. Right. So now we have discussed the COPD. What happens to FV loop in COPD? I think you are now very well aware. Now we'll go on to the next part, and that is restrictive lung disease. One more thing which can happen to in a COPD patient. Suppose there is an emphysema. What happens to total lung capacity in emphysema? So as you know, in emphysema, there is increase in the total lung capacity. So this this point may be a little bit on the left side. So there will be left shift of this curve. Okay, so we will explain this in next slide. We just learn this in the next slide, definitely. Okay, so now this is a case of restrictive lung disease where you can see the lung has been studied by multiple opacities, okay, multiple infiltrations, and this could be a fibrosis. Okay, so the lung volumes will be diminished. Restrictive lung disease means all the capacity and volumes of the lungs will be diminished. So how the FV loop will look like. So let's see. So this will look like this. Okay. So this is your F.V loop in case of restricted lung disease. So what will happen? So there will be drop in the peak expiratory flow. There will be little drop in the peak expiratory flow as well. What happens to the total lung capacity? It also decreases. So there is a right shift in the F.V loop, and there is a decrease in the residual volume. Can you see? So there is, so from here 0 to this point there is a residual volume, and what happens? So just to remember, the residual volume here may be 1.5 liter in a normal case, 1.5 to 2 liter, and here it has become like 500 ml to 750 ml only. Okay, so this much. So residual volume decreased, TLC also decreased, and PEFR is also decreased, and also there is decrease in the peak inspiratory flow. So everything is decreased. So this loop becomes smaller in area, and there is the right shift. Okay, so that is your restrictive lung disease. Fine. Now observe the F.V loops below and what pulmonary diseases are represented by loop 1 and loop 2. This is the question for you. So loop A and loop B. So this is your normal, the middle one. What is this loop? Loop A is, so I'm sorry, this is not an interactive class. Maybe you will be listening to or watching this video, which is recorded now. So I cannot get responses from you. So, but yes, I will tell you for your information. I think you have guessed it well so far that this is your COPD, right? This is a scooped out appearance, and PEFR is also less than normal. So this is a severe COPD. Because of severe COPD, there is a greater decrease in peak expiratory flow rate. Okay, and there is a drop in the peak expiratory flow rate as well. Okay, and there is a left shift, as you can see. So TLC will be more, all right, and there will be more residual volume as well in case of COPD. Residual volume can be normal as well. So normal to high residual volume, increase in residual volume, increase in TLC in case of COPD. Now this curve, look at B curve. In B curve, there is a left, there is a right shift. So all the volumes and all the capacities, all the peak flow rate, everything is decreased here, and that is your restricted lung disease. So A is COPD and B is restricted lung disease. Okay, as simple as that. Now observe this F.V loop. What does a loop B represent? So this is normal loop. A loop is actually normal. Okay, this is a real-time loop which was drawn in year 1975. I have obtained it from one article. I'm sorry, I forgot to mention. I forgot to give a reference for this article. But look at this loop. So what is happening here? So there is a decrease in the peak expiratory flow rate. There is a decrease in the peak inspiratory flow rate as well. There is no change in the TLC. Residual volume increased. Okay, but vital capacity also diminished. Okay, so what is this case? What is happening? So you could say that there may be a fixed airway obstruction. But the only thing is, which is against this diagnosis, is that there is no plateau. There is no flattening of curve. Okay, so this is pointed one here. So this is just a kind of normal loop with a less volume. So this is your restrictive lung disease. And okay, and this has been obtained in a patient who had a neuromuscular disease, basically quadriplegia. So this curve represents the quadriplegia, where the patient was having all the capacities and lung volumes low. Okay, so this is another example for restrictive lung disease. Now we will come to F.V loop. So far we have discussed the F.V loop in spontaneously breathing patients, especially the patients who will come to you for the pre-anesthetic checkup. And you will look at the F.V loop and then try to find out what kind of disease they have. Now what happens when patient is in ICU and they are mechanically ventilated? So how to draw, what are the things which we should know? Okay, so this is your flow volume loop for the spontaneously breathing patient. Flow at y-axis, volume at x-axis, and this is your inspiration, this is your expression. So expression at a positive side, inspiration at a negative side. Okay, so you start from total lung capacity here, and then you expire, and then you go down, and then you just finish at the residual volume. So this is your usual, which actually I have already covered in my previous slide. Okay, expression and aspiration, FV loop in a spontaneously breathing patient. Now let's examine the FV loop in the mechanically ventilated patients. So same thing, but we are drawing over the right side. Okay, so on the positive side. So what we do is, there is a difference. So flow will be in the liter per minute, not in the liter per second. And volume will, the unit will change. It will be in ml, milliliter. And we start from 0, and then like this. Okay, so we start from here. This is your residual volume, and we inspire. Okay, this is your inspiration, and this is your maximal inspiratory flow rate. And then we go down. Okay, the inspiratory flow decreases to the minimum and becomes 0 at this point, and this point is actually a tidal volume. So we don't have total lung capacity, capacity here. We have the tidal volume. Okay, this is the main difference between the spontaneously breathing and mechanically ventilated patients. So we don't have DLC, we have tidal volume here, which we are delivering to patients in each breath. Okay, so this is in the ml. Usually we ventilate with 6 to 8 ml per kg body weight, or 5 to 6 ml per kg of body weight of tidal volume. So this will be in ml. All right, and this part is basically the active inspiration. So inspiration will always be active, and expiration will be kind of recoil of lungs, so that will be passive. So passive expiration, active inspiration. Whereas in spontaneously breathing patient, it will be very, very active inspiration and uh, voluntary inspiration. Okay, so this is the main difference. So active inspiration and the passive expiration in case of FV loop of mechanically ventilated patient. Now we will look at what happens to various situations. All right, so let's find out. So this is your peak expiratory flow rate. So expiration is down here. So this is your peak expiratory flow rate, and then you have peak inspiratory flow rate above, like this. All right. Now we will know various conditions in which all these things are affected. So let's discuss the obstruction. So in obstructive airway diseases like COPD, usually we don't discuss airway obstruction because patients are usually intubated, the tracheal obstructions are already bypassed. So we don't discuss the upper airway obstruction and all. We just discuss the lower airway obstruction, that is your COPD. And in case of COPD, you will see in the expiratory limb, which is down in case of mechanically ventilated patient, there will be a scooped out appearance, as you have seen in the spontaneously breathing patient, right? Same thing here, but on the other side, scooped out appearance. And there are other findings also. There will be decrease in the peak expiratory flow rate, as we have seen in the spontaneously breathing patient. Same here. So scooped out expiration, reduced peak expiratory flow rate. And one more thing which happens here is that expiration ends just before the baseline. Okay, so it does not reach to the baseline, does not reach to 0. Okay, so it just stops here, and there is some volume left, which is called volume trapping. So in COPD, the expression does not complete at all. So there will always be inspiration. It starts just before complete expiration, and there will be some air which will be trapped inside the alveoli, and that will give rise to autopeep or intrinsic peep. Okay, so this volume is called the volume trap. And now this is your inspiration. So even inspiration is blunted here. So peak inspiratory flow rate and peak expiratory flow rate both will be diminished. Okay. Now what happens in restriction in respiratory lung disease to this FV loop in mechanically ventilated patient? Can you guess? Yes. So there will be decrease in everything. All right, but there will be shift of this curve. So there will be decrease in the peak inspiratory flow rate, and there will be leftward shift towards left side of this inspiratory curve and expiratory curve both. So whole loop will be shifted. All right, so this is your usual restrictive lung disease, and there will be little bit increase in the peak expiratory flow rate. So there are three findings related to restrictive lung disease in mechanically ventilated patient. As far as F.V loop is concerned, there will be low tidal volume, first of all. So as you can see, the tidal volume has reduced because, as you know, this is your residual volume and this is your tidal volume. So tidal volume has definitely diminished a lot. So there will be restricted tidal volume delivery, and there will be rapid decrease in the inspiratory flow. There will be decrease in the expiratory flow also. Okay, so that is your restrictive lung disease. I hope you will remember all these. Now, what happens when there is a circuit leak? Okay, this is also interesting. So in circuit leak, like this, so there will be normal inspiratory flow, but in expiration, it will just complete before, it will not meet the initial point. So it will just complete before reaching to inspirate. So it will abruptly ends before, right? So this is what it is. So there will be some lag, and this lag is known as leak. Okay, so this will represent as a leak, very typical of a loop in patients who have some leak in circuit, or there is a cough which is not properly inflated, the endotracheal tube cough or tracheostomy tube cough. So definitely you put the patient on F.V loop, look at the screen, and you will find this kind of loop. Okay, what happens when there are secretions in the trachea and endotracheal tube or in the respiratory system? So expiration will be completely okay, fine, but expiration, during expiration, there will be a zigzag, appearance like this, the turbulations. So these turbulations are because of secretions in the trachea. It is kind of obstructing the flow. That is why it appears. So there is a little bit of a scooped out appearance also, and there will be zigzag pattern. That this pattern is known as is basically due to the secretions in the trachea. All right, so I have covered almost all the types of F.V loops in this teaching session. I hope this will be very useful for all of you guys, and it will help you in giving you more clarity to this topic, and you will be more confident in speaking and your viva, and you will come out with flying colors, okay, and successful in your exit exam for anesthesiology. So thank you so much for your help, and for your listening, patient listening, and I mean, I could not interact with you. I think there are some things in the chat. Okay, okay. RLD. What do you mean? I think this is restrictive lung disease. Okay, and so I think you don't have any question. If you have any question, you can ask if you are online. And this is my YouTube channel. There are two channels I have for the patient, for the students who have critical care, in mind as a career, and they want to learn more. So these two are my channels in which I'm just giving some tips and educations, some important lectures. Okay. So do you have any question for related to F.V loops? If any question, it is all welcome. I will be happy to answer. And that's all for today. Thank you so much.